she did was, she said, you have to follow you. So she took his pants off and took his underwear off, and she was so gentle, and next thing I knew, she was standing out of the room, and her eyes were this big. Okay, what'd you do? Yeah, he did get an erection. Well, we had to wait a little while before we had to go in. So firmly, okay? I'm not meaning to do, you don't do. But firmly. Don't wrestle with it. Okay. Okay. Warning signs regarding testicular self-exam. Got painless swelling. Okay, a lump that's the size of a pea-sized lump. Okay, any fluid accumulation in the scrotum. If you see the scrotum is sort of enlarged and you might think that there's fluid in it, how can you tell whether it's clear fluid or blood? Flashlight. You take a flashlight and you shine, you put it underneath the scrotum, and if you can see that it's translucent, then you know it's fluid, not blood. So the old flashlight trick works real well. So all those pen lights that we told you to get, and you thought we wanted you to check pupils. Mm-hmm. Another warning sign is a dull ache in the groin or the lower scrotum or the lower abdomen. Okay, like I said, any pain, and pain is not good. Pain is nature's way of telling you there's something wrong. So if there's pain, you need to do something about it. Okay. And with men, any enlargement or tenderness of the breast. Yes, I did say breast. And why is that? Because women, we produce estrogen primarily, but we also produce progestin. And progestin is a male hormone. It's an androgen. Men, you all primarily produce progesterone or testosterone. I know you all have testosterone fits every so often. Got to go to Home Depot and buy that tool when you have a testosterone fit. I know. Okay. My husband does this all the time. But you produce not only testosterone, you also do produce female hormones. So if you have an enlargement or tenderness of the breast, that could be a warning sign. In point of fact, I had a patient who he was 38 years old, and he got cancer of the breast. Yeah. So, it's certainly a possibility. Okay, let's talk about breast cancer. All right, everyone, I got everyone's attention. All the men are looking up now. Yes. Self-breast exam is the most important intervention. The most important intervention. Not prevention, but intervention. That's an NCLEX question also. They ask you which of the following is the best prevention of breast cancer. They will put SBE up there. Performing a self-breast exam does not prevent cancer. It is an early detection, so it's an important intervention, so don't get fooled. Read the question carefully. Okay, if self-breast exams prevented cancer, we'd all be running around massaging our breasts all day long. Okay, self-breast exams do not prevent, they're good intervention. Okay, some of the advanced signs and symptoms of breast cancer include what? Discharge from the nipples, a dimpling of the nipples, that orange peel skin. Yes? So remember we talked about having a mammogram done? Well, at the age of 40, you need a baseline mammo. And after that, you should do it every 1 to 2 years after. Now, why do we say 1 to 2? If your initial baseline was negative, what they tell you is that it's okay if you choose, instead of doing it next year, to do it 2 years from now. Now, has every woman in this room had a mammogram done? It is probably the most painful thing. It's extremely painful. They take your breast and squeeze it down to the size of a pancake. It hurts. Yes? And then when you walk out of there, you go, I am deformed for life. Because they mush it down, and it hurts. It really does. So I understand when clients of mine or patients of mine tell me, I don't want a mammogram. It hurts. I understand that. Okay? Our job, however, is to just encourage them to go for a mammogram. They're much better today. They're more humane today. It hurts less. I know I just had one done a few months ago. It hurts less, but it still hurts. It still darn hurts. Okay. And they'll squish it this way and this way. Oh, you are deformed for life when you come out of there. After the age of 50, though, you have no choice. It should be every year. As far as any cancer is concerned, and this is a question that I am going to throw out at you, for any cancer, whether it's liver, whether it's kidneys, whether it's bladder or breast or testicles or prostate, the most definitive diagnosis for any cancer is the biopsy. The biopsy. That is your most definitive diagnostic test, because it's only with the biopsy that they can actually look under a microscope to see if the cells are indeed cancerous or not, if they're well differentiated or poorly differentiated. Okay? If they're poorly differentiated, that's not a good sign. That's what we're looking at. Signs and symptoms of breast cancer. Well, the earliest sign is an abnormal mammography. The second earliest sign is a palpable mass, okay, in the breast. Now, has anyone ever felt a cancerous lump in the breast? It feels like a very hard pea. Normal lumps and bumps that you feel, all women in this world have a little bit of fibrosis, a little bit of fibrotic tissue in our breasts. Those normal, you palpate and you go, oh, ouch, that hurts, and it's a lumpy thing. That's good. That's okay. That is not cancerous. A cancerous lump it's actually hard, and it feels like a hard pea. We talked about advanced signs already. The advanced signs are the nipple retraction or the discharge. Okay, the dimpling of the skin, orange peel skin, and the change in the breast contour. So, therefore, every month when you all are doing your self-breast exams, you're looking at your breast, you should also do this. You should also stand in front of a mirror, and everyone's going, what? No, I can't look at myself naked. Stand in front of the mirror, naked from the waist up. Put your hands on your hips, okay, hands on your hips, and just look in the mirror to make sure that the contours of your breasts are about equal. Now, we all know, women will tell you, we all know that one breast is usually a little bit smaller than the other. But when I'm not talking about that, I'm talking about the contour, okay? That the contour is about equal. There's no bump in, indentation in the breast or anything like that. There's no dimpling, okay? There's no nipple retraction. All right. Now I had a patient come up to me because when I was giving her some teaching about nipple retraction, her eyes got real big, and I said, "What's the matter?" She says, "My nipples are always retracted." Well, if that's normal for you, that's normal for you. There's not a sign of cancer. So you got to also remember that, some people do have retracted nipples. And so that's normal. Don't get worried about it. So it's something that you have to reassure them. What's the treatment? Well, my little theory, for cancer is that the tendency, what we tend to do in the medical profession is that we tend to treat any cancer by three methods. We slash, burn, or poison. We slash, meaning we cut it out. We burn, meaning we irradiate. We poison, meaning we give chemotherapy. And you better believe chemo is poison. So slash, burn, or poison, that's what we do. And if you can remember that, okay, it'll help you. So the treatment for breast cancer, radiation, you can have a modified radical mastectomy, or you can have a radical mastectomy. Okay, a modified radical mastectomy, they remove the breast and maybe a couple of lymph nodes. When you do a complete radical, then it's the whole breast and all the lymph nodes down that one side, that particular side. So what are your nursing interventions then? Your nursing interventions before the radical mass, okay, before the surgery, is encouragement. Now, there are women, okay, who the loss of a breast to them is the loss of their womanhood, their femininity, because this to them, because society, we've always said this, that women have breasts and that's what makes them women, and the bigger the better, okay? Yes. So that's been a symbol of womanhood. Okay? When you're 12 or 13 and you get into the puberty stage and you get breast buds and you begin to become a woman, this is like a rite de passage. It's a big, very important thing for women. Okay? So a lot of encouragement before, because they are going to go through, and they have a huge sense of loss and grieving. They're absolutely going to be grieving the loss. It's like the death of a breast. Okay? They're really going to be doing that. Post-operatively, and you do some of your teaching pre-op, okay? You may not be able to do as much pre-operatively as post-operatively, because remember, pre-op, they may be in the huge grieving stage. So for you to want to give them information like, oh, you know, after surgery, we're going to be doing these exercises, they really may not want to listen to you. So you'll have to gauge your patient, each patient, okay, as an individual. Now, NCLEX will say to you that you need to do your teaching pre-operatively. Fine. That's what NCLEX wants, and that's the ideal world. I'm saying to you that in the real world, you really need to gauge each individual patient on his or her own merits as to whether you can get through or not. Okay, sometimes you can't. But post-operatively, you know that this breast is going to be gone. Okay? So you need to encourage, and a lot of times the lymph nodes are gone also. And the lymph nodes, as you know, is another part of our circulatory system, and it brings back, it helps circulate back to the heart fluid. If we don't have our lymph nodes, then we end up with edema down that one arm or that one side. Okay? So you need to tell them that post-operatively, and post-operatively you're going to start encouraging just finger movements. When they come out of surgery, that arm is going to be right close to them. Okay, it's going to be adducted, A-D, adducted. Okay, by the time they get to go home, though, you're going to want, if the drains have come out, okay, once the drains are out, then you tell them to abduct, abduct. Okay, so you move away, because at this point in time, you want to encourage the stretching, and you want to discourage the contraction. Remember, when a scar forms, it contracts the skin, yes? So you want to discharge that, and you want to abduct. So you want to tell them, put your arm up on a pillow, play with a rubber ball, reach as much as you can. And in fact, there's a group, a national group for breast cancer survivors called Reach to Recovery. So essentially, when they're in the hospital, they're going to come have Jackson Pratts. All right, they're going to have Jackson Pratts in their breast. It's going to be draining. As long as they have the Jackson Pratts in and it's draining, you adduct. You bring the arm in. Once they're home and the Jackson Pratts are out, they abduct. Okay? All right, let's talk now about some adverse effects of chemotherapy. Well, this is the poison part, and we remember that chemo is a poison. And we remember that chemo works how? By destroying rapidly growing cells, correct? Rapidly growing cells. So everything that grows fast, replicates quickly, gets destroyed. Cancer cells replicate very quickly. That's why they're poorly differentiated. Okay, they don't have any definitive. If you look at a regular cell, you can see the nucleus, the mitochondria, the Golgi apparatus. You can see the ribosomes. That's well differentiated because you can tell the difference between each. Cancer cells replicate very quickly so that if you look at it under a microscope, you can't tell. Only thing you can tell maybe is the nucleus. But can you tell by the Golgi apparatus, the mitochondria, the ribosomes? Cannot tell. So they're poorly differentiated. Okay? Chemo destroys cancer cells because they're rapidly growing. They also destroy everything in your body that's rapidly growing. And so what's rapidly growing in your body? Your skin, your hair, your mucous membranes, your red blood cells, your white blood cells. These are relatively rapid growing. Okay? That's why with chemotherapy you get hair loss, you get stomatitis, because your mucous membranes, yet you get ulcerations in your mouth all the way down to your rectum. And this is why people don't want to eat. Hurts, painful. They have no sense of taste. Okay? That's why chemotherapy patients become anemic. That's why they're also more susceptible to infections, because their white cells are destroyed. So therefore, does that make sense then to you if I say to you that if a person's undergoing chemotherapy, we're going to draw blood you're going to get your chemotherapy today, okay? And before we give the next chemotherapy treatment, we're going to draw your blood and we're going to check your H&H and your white cell count before we do another.